Okay, good evening, everybody. Okay, we got a lot of people here tonight. First and foremost, I want to say thank you and hello first. My name is Joseph Paul Javier, and I'm the current president for our Wayne State chapter of AMCP. And it's a pleasure to have this seminar late in the evening. Hopefully you've had your dinner and are ready to learn about monographs because we got a jam-packed session prepared for you guys. I can see from the names here on the screen that we have a lot of our members that are interested, in forming teams that have showed interest in our first ever local competition for the P&T competition here at Wayne State. So pay attention, take some notes. We are recording tonight's seminar and we'll be uploading it to our Wayne State AMCP YouTube channel. So you can review that to help you when you start working on your contest submissions. So with that, I just want to say hello and acknowledge the presence of our immediate past president, Fadi Manuel. He's here on the Zoom call, as well as our president-elect, Jacqueline Fleury. Jackie's there, and to all of our other e-board members and potential leadership team members, because I see a lot of the people that applied to join our e-board are also here at this meeting. It's, we've come a long way here with our chapter. We're still a young chapter compared to other chapters all around the region and nationally of AMCP. But our guest today that will be giving our seminar is very special because he's actually one of the founding members of our chapter here at Wayne State University. So I could go into more detail. He was part of the team last year that competed in the national competition for the P&T competition. And if you haven't heard by now, Wayne State University, we got into AMCP and made a big bang. Our first year competing, we won second place in all of the nation, thanks in part to our speaker this evening. So ladies and gentlemen, without further ado, I'd like to introduce to you, Dr. Shivan Patel.
Thank you for that introduction, Joseph. I really appreciate it. I want to first say thank you to Wayne State's AMCP chapter for inviting me. I'm honored and I'm thrilled to kind of share my knowledge and expertise with you all. 31 participants, I'm ecstatic. Never in my wildest dreams did I think that when we started AMCP, we'd have, within the 3 years, we'd have 31 participants joining just interested in the P&T competition. So I'm excited. I definitely appreciate all of you joining in and tuning in today, and I hope you find today's session very informative. So with that, I will go and share my screen and get today's presentation started. Make sure we're... All right, can everyone see the full screen? Perfect. Okay, so today's session is on Intro to Drug Monographs. As mentioned earlier, my name is Shivan Patel. I'm a class of 2021 Wayne State College of Pharmacy graduate, so just finished in April, May of this year. Before we get into today's presentation, just a little bit about me. I completed my undergrad studies from 2014 to 2017 at Wayne State, and then my PharmD from 2018 to 2022. Post-graduation, I am now a postdoc fellow with the Rutgers Institute for Pharmaceutical Industry Fellowships in collaboration with the pharmaceutical company called Sanofi. I just started in July into the 2-year fellowship in patient value and market strategy. And just a little bit about how this P&T competition has helped me. Great, we did get second place nationally last year, which is quite rare. Very few established chapters ever get to that high level, and we luckily got it our first year through some hard work and a little bit of luck. So how a P&T competition works and what it's useful for is it's a great CV builder. To have this competition experience is extremely valuable, as well as the fact that no matter where you practice, whether it's in the community, in the hospital, managed care industry, consulting, wherever, P&T competitions are always, a P&T committee is always going to meet, whether it's from a drug as basic as lisinopril, all the way up to gene therapy. Every drug is going to go through a pharmacy and therapeutics committee, and you as a pharmacist will be an integral part of that. And to build these skills early on within your pharmacy school career will be extremely important so you can hit the ground running when you do officially start working in those committees, regardless of your career option. So before we get started, I just want to kind of get a quick raise of hands through the function. Have any of you guys done a drug monograph? I do remember in SAS, our P2 year, we did have a drug monograph assignment. So I just wanted to get a raise of hands to see if anyone has had some experience making a monograph or kind of reading one and putting one together. Okay, so I saw a couple of hands. So there's some experience, but if you haven't, it's not the end of the world. We'll kind of go through it today. So what is a monograph and what's its role? So a monograph is essentially an overview and an evaluation. It's very important, an evaluation of a drug. You're going to compare its therapeutic classes. You're going to compare it to its disease state and how other mechanistic drugs compare to that disease. You're going to talk about efficacy, safety, cost, and give your own recommendations after you've collectively assessed and evaluated all of the information. Typically, these are prepared by pharmacists, so you guys are the most well-equipped individuals to perform this when you do go in the real world. And sometimes you'll have other individuals be involved. You'll have other healthcare providers be involved in the process, as they can provide unique perspectives as well. So when do we need a monograph? At what stage of development is this in? So we can see on the left-hand side, this is pre-launch. This is probably a little bit during the phase 3 trials. And then a P&T committee is really going to meet in the first 3 to 6 months after a drug has been approved. This is the most important part. This is when we have all of the phase 3 data. The FDA has given us the green light. And now 3 to 6 months in, it's our job as a committee to make a decision of how we want to utilize this drug. How do we want to tier it, prior authorizations, what kind of restrictions do we want to put on it, and how is it going to ultimately impact the health of our patients, which is the most important part. So as you know, when you're preparing for a P&T committee, we're at the last step, a drug monograph prepared for a P&T committee, but there's a lot of steps that go in before that. First, you really have to understand the literature. So this is where your P1 year literature analysis course is going to come into play. You will need those skills to be successful in doing this competition. You'll have to look at the published data. You'll have to look at what the pharmaceutical company has provided. You'll have to make your own independent comparisons with other drugs. And you'll have to kind of evaluate all this data to ultimately prepare a drug monograph, which is the end goal of this competition. So a little bit about what a monograph includes. There's 5 main sections, and then the 5th section is broken up further. So there's an executive summary, there's evidence gaps, a value and operational matrix, recommendations to the committee, and then the clinical evidence evaluation, which is broken down further on the right-hand side. We'll take some time and go in depth into each of the sections and talk about what's required, some tips, some goals, and things that you can do to make yourself as successful as possible. And I did forget to mention this earlier. However, if you guys do have questions, feel free to raise your hand. You can pop them in the chat, or you can wait till the end of the presentation when we can open the floor to any questions or advice that people on this call will have. So first, an executive summary. So the goal of this executive summary, it's the first 2 pages of your monograph, and it's essentially, if a P&T committee member had 1 minute to look at your monograph, they're going to read these first 2 pages and know what you wanted to do. It's going to contain every single little bit of information succinctly written down in 1 or 2 pages so that a P&T member doesn't even have to go through the rest of the monograph and they know what you want to do. So you're going to look at clinical trials, the efficacy, you're going to look at the safety, you're going to look at a couple other things that I'll mention later on. Key takeaways for the P&T competition specifically, your executive summary should never be longer than 3 pages. 2 pages is usually a really good balance and a mix to get all the information. Each section is about a paragraph. So the point of the summary is to be direct, to be to the point. So really no fluffy language, no kind of long drawn out sentences. Just be direct to the point of why you've chosen the path that you've chosen for your drug. And then you really want to assess. In this case, to make an executive summary, you really need to assess how robust your evidence is. As you see on the right-hand side, you need to show the strength of evidence. So is the efficacy in the clinical trial, is based on your assessment, is it low strength? Is it high strength, and why? And to do this, you really need to assess the robustness of the trial. And this can include assessing gender breakdown, race breakdown, ethnicity, or even underserved populations that you found in your research. And you should also check if appropriate statistics were used. Were the right statistical tests used? Was the power correct? Were certain endpoints significant versus other endpoints? And were those endpoints extremely clinically relevant in the real world to the patients that we want to care about? Some other portions of the executive summary will be 3 things: your real world comparative effectiveness, your value proposition, and your target patient subgroups. So your real world comparative effectiveness is really how is your drug comparing to other drugs with the same mechanism of action? So it's your job to do a competitive landscape evaluation essentially and see what other drugs that other companies have had, what's on the market, how do they function, what's their strong points, what's their weak points, are they safer than our drug, are they more dangerous than our drug, what's the efficacy like compared, are there any black box warnings, are there any FDA alerts that have been mentioned that can really give your drug and another drug with the same mechanism of action a head-to-head comparison. The value proposition is really from your assessment as a pharmacy student, does the clinical data justify the economic impact? So does that mean, is it too expensive for the benefit that it's giving? Is it just right? Is it actually priced way less and a great deal for a patient to get? In this case, ICER is your friend. So for those of you that don't know, ICER's Institute, it's for economic research. And this is the leading institution for all things pharmaceutical drug related pricing and value. So really you want to look at ICER and see if ICER has come up with any white papers, any evidence, any comments about this drug or this disease state, and utilize that. ICER is the highest of the high, it's like the gold standard. So really see if they have anything. And if they do, check it out and see how you can incorporate that into your P&T monograph. Other things in the value, frequency, route of administration, and access are also really important. So are we once a day versus someone else being twice a day? Are we a sub-Q versus oral? Are we IM? And access, can I self-administer it at my house, or do I have to go to the doctor's office twice a week to get the drug? All these little things can add up and really make a big difference in value to our patient. And then subgroups, who is the drug meant for? Is it meant for all people over the age of 65, for example? Or is it really meant for patients who have failed the first line of therapy and then our drug ends up being the best second line option available? It's your job to assess that based on the literature. What's the burden of the disease? Is it high burden, low burden? Who is it most burdensome to? And does this drug have an unmet need? We really have to understand that because we're trying to place this drug into a certain tier system. So what unmet need is there that our drug will kind of fill that gap in for? And that's really the key of what you want to get in the overall monograph, but also in your executive summary. Evidence gaps. This is another little bit. It's kind of broken down into the PCOT elements. So this is really helping the P&T committee understand the limitations of your research. It does a really great job of helping the P&T committee see where you've done your research, how thorough you've been in your research, and what kind of unmet needs are there that really kind of hindered you in making your final conclusion. And sometimes this is a very big tip. I know as students, we hate not knowing. And oftentimes in school, we really, if you don't have the answer, it's wrong. It feels uneasy. But sometimes no evidence is actually more powerful than having a lot of evidence. If you don't have evidence for a certain population, for a certain comparator, that's very valuable because you know that's not there and that's an unmet need. That's something that needs to be explored further. And the revelation of that new little pocket of evidence can really change your decision. And it's that critical thinking and evaluation that will really help you score points with the P&T committee. So with populations, you want to look at how well do the subjects in my trial compare to my health plan's patients. So within the P&T committee, you'll be pretend on a health plan. So this health plan will give you the number of patients it has, the breakdown of male versus female, the breakdown of age. So you really want to see, did their pivotal phase 3 trial correlate to how my health plan is set up? If so, great. But if not, where are those gaps and how do we need to evaluate that when we're coming to our conclusion? Intervention is the actual intervention or the therapy clearly described, and is it practical? Can I really do this in the real world, and can a patient do it in the real world over the course of 1, 2, or 3 years? Comparator, do the clinical trials include a comparator of interest for our health plan? Are we comparing it head to head versus a drug that we already have in tier 1? Or is it compared against a placebo where it makes our job a little bit more difficult in evaluating the different mechanisms, the different drugs with the same mechanism of action? Outcome, are endpoints clinically meaningful and appropriately and accurately assessed? Are these meaningful outcomes that our patients want and that would help us as a health plan? Sometimes, there might be big ones like reduced hospitalization, which is extremely meaningful to both patients and health plans, but there may be smaller ones such as nausea, vomiting, which are impactful to patients, but maybe not as impactful to a health plan. So you really need to understand, is the outcome tested clinically meaningful? How meaningful is it? And how is it going to impact you and your patients? And then time frame. Is the duration of follow-up enough? So I'll give you a tip from last year. Last year, we had a drug that was really brand new, and they only essentially tested the safety for about 6 months after they started the drug. And the biggest risk was risk of falls in elderly patients. And as you all know, risk of falls is one of the highest leading causes of hospitalization, death, and kind of overall trauma for an elderly individual. And 6 months is not really a long time to assess the impact of this drug on falls. So we kind of made that point and decided that we need to find more evidence, and we want more longitudinal trials to really evaluate the safety portion of our drug. And then lastly, you'll be talking about some of the unanswered questions. So what questions do you still have? And you want to put questions in this section that if they were answered, they would improve your level of confidence in your recommendation. So really questions that you really think would be impactful, or data that you would find impactful in helping you clarify and strengthen your argument for your decision. Okay, next part is value and operational matrix. So I took this screenshot directly from the P&T monograph that we had last year. This is just a really quick pre-fill kind of chart that you're going to be doing. So you're going to be kind of assessing, does this product improve over the current standard of care? And it's your job to decide none, minimal, modest, substantial, or cure. Other societal considerations, are there different things that you've noticed from patient perspectives that you think are really impactful to consider as a health plan that maybe aren't so obvious in the literature of the phase 3 trial? The incremental cost effectiveness ratio, you'll have estimates that you'll find in literature. If it's not there, it's okay. Formulary recommendation, you can include it, optionally include it, or do not include. Budget impact and utilization management. These are things that I'll touch on later. But also, I just want to make a point that there's no right answer. There's never a right answer for the P&T competition monograph. Like, it's not like with this drug, you have to do a definite include, or you should only do an optional include with step therapy and prior authorization. There's no wrong answer. There's no right answer. The point is that you came to a conclusion evaluating all of the evidence that you were able to find, and you came to it in a very logical and reasonable way for a pharmacy student to kind of think through and assess given their level of expertise, and that it's something that you can improve upon, but also that's something that's realistic in the real world as well. So just remember, there's no right answer, there's no wrong answer, just how do you explain how you got to your end point. Recommendations to the committee. So this is going to be just a one pager. You're going to write 2 paragraphs that essentially justify why you chose what you chose in the value and operational matrix. So how effective is the product? If it's more expensive, does it really offer a meaningful incremental net benefit in terms of clinical outcomes? Are there safety concerns? Essentially, you really just want to show why you chose what you did and give breakdowns of each thing. If you did a prior authorization, tell them what your criteria are. Is it patient needs to be over 18? They can't have certain conditions that are contraindicated. They need to go through XYZ therapy first that's on our formulary. Just write it out to one pager, very quick and easy. It's just kind of a little way to describe and talk through how you came to your decision. Now, this is where we get into the bulk of our monograph. So the first couple things I mentioned, that will be the maybe first 7 to 8 pages of your monograph. These are very quick summary things, very nice ways to keep things standardized across all teams and all different chapters so that we can get to your conclusions very quickly. However, the competition is won in this section. It's this clinical evidence evaluation and all the 6 parts that come with it. This can range from anywhere from 30 pages to upwards of 70 to 80 pages. This is where you are essentially putting all the research and work that you've done over however long, over a couple of months, into writing. You're putting it into a well-organized, well-detailed kind of plan to show how you got to each of the conclusions, what evidence you went through, what you thought of the evidence, and kind of how you discussed through it and what thoughts came in your head. This is where a competition is won, by all means. So in the evidence evaluation, it's efficacy. So you're going to give a full narrative summary of the evidence. You're going to talk about every single study that you saw, what are the positives of the drugs? What are the negatives of the drug? You're going to give a full detailed summary. This could range from 2 pages. This could be 10 pages. Really talk through, depends on how much data and evidence the drug has and how new it is to market, but you're really going to go into really big detail. Safety just as important. So we're going to do a full analysis of the safety. So you're going to discuss the impact of clinically important adverse events. And I highlighted and bolded clinically important because it's also highlighted and bolded within their rubric as well as their kind of draft monograph. In this case, we really want to look at what's important. So if I go back to last year's example, elderly patient falls is clinically important. For the drug we had last year, nausea, vomiting isn't as important. It's still an adverse event that we want to take consideration of, but falls and kind of somnolence and sleepiness and things like that are all clinically important to our patients and could lead to further health damages. If a patient falls to hospitalization, it's a negative impact on our patients and a health plan as a whole. So you want to make sure these adverse events are serious enough that they come into your head when you're thinking about risk versus benefit of a drug. So pretend like you're a pharmacist at a hospital or an outpatient clinic, and you kind of have to think through, the doctor prescribed this, will I approve it? Think through that and what safety things came in your head when you're making that risk consideration. Those are the kind of adverse events that you want to be talking about in this. And also, if there's post-market data available, absolutely put that in. Then you can compare it to what was done pre-market, and you can compare that evidence and really utilize that to your benefit. And you can also afterwards, you can put other adverse events that are not of serious harms, but really patients might kind of feel them. And you want to check the impact on different groups. Do younger patients have more of an impact for a certain adverse event versus older patients? How is that a negative impact? Is it maybe something that a child might miss school on? And that's a kind of it's hard to put a dollar value on that, but it's important because when the child has to miss school, maybe the parent also has to go off of work to take care of the child. The child is missing school, which is kind of detrimental to their development, things like that. And then also tolerability. Are patients able to take the medication? Because if we put all this work in and make this drug a tier 1, but our patients can't handle the drug for more than a month, it's really not appropriate to put that in a tier 1 because so many of our patients will be failing this therapy. And then patient subgroups. So this is really, you need to understand, is this drug going to be working for everyone, or is it only working for certain populations? So going back to the example earlier, is it really only for patients that failed the first-line therapy? Is it only for patients who have tried 3 drugs before? Is it for everybody? You got to make that decision based off the literature. And also you can just include different things like biomarkers or other diagnostic tools that you can use to track progress, track efficacy, that you might want to include as a health plan and say, we want our prescribers to do this with our patients every 6 months for this drug, so that we can continually track the efficacy of it and make sure that we're making the appropriate financial and clinical decision for our patients, given our evidence and knowledge of the drug. Next is the economic evidence evaluation. And I will say this is probably the toughest part, simply because as pharmacy students, we don't necessarily have as much background knowledge in this section. So this may take a little bit of time. It's going to require a lot of reading and research, trial and error. I know as a P3, there is a pharmaceutical economics elective. I know that on our team last year, 3 of us had taken that. We found that very helpful, but by no means is it a prerequisite. A lot of this information can be found online. There's a lot of YouTube videos as well, and just different kind of resources to help you understand what's required in an economic evidence evaluation. So this is really where you're going to summarize all the pharmacoeconomic info that's available. So this might be from a manufacturer. Some manufacturers like to provide that information. This might be from external studies from ICER, for example, or either health technology assessment sources that are provided. So you're going to provide the value. What value does this drug bring? It could be economic value. It could be intangible clinical value. What subpopulations would benefit more or less? Has the manufacturer come out with a value proposition? So for some more expensive, more niche drugs, manufacturers themselves come out with their rationale for why they priced it as such and what value they think it provides to a patient. Include that, whether you agree with it or not. It's still very important to include that because that's one massive perspective that you want to incorporate. And then you can maybe give a rebuttal for why you don't agree with it, or you can give some evidence for why you do agree with it. And you also want to assess the impact on the overall healthcare cost and plan. That's ultimately what we're doing. Is this drug going to increase our members' monthly charge because it's so expensive and the uptake is going to be so high? And if so, is it worth it? Or is it really not going to impact our healthcare costs as a managed care plan, but it's still providing benefit? That's kind of up to you. The ICER, it's the incremental cost effectiveness ratio. You're going to look at, is there an ICER done for this drug or disease state? ICER provides, I should kind of break this up. There's ICER, the acronym, and ICER, the organization. So ICER, the acronym, is incremental cost effectiveness ratio. That's the way that we can compare differences between specific drugs with their overall quality of life benefit. And then ICER, the organization, is the big organization that really heads kind of how we determine this in the United States. So you want to see if there's an incremental cost effectiveness ratio done for this drug or disease state, and include a quantitative review. And why I say quantitative, this is also specified in the rubric. So just look at the numbers, assess the numbers, and see what the leading gold standard authorities think about this. And then in your summary, you can discuss it. You can give some qualitative analysis. You can give a discussion. You can think, you can talk about why you agree with it, why you don't agree with it. Maybe that there's some variables that you're like, you know what, in the updated research, these don't make sense. I'm going to rerun it myself, and this is the number that I got. And then budget impact, you're going to talk to the committee through your budget impact model. So you're going to be required to make a budget impact model. They give you a base case, and then it's your job to change it based off of your research and what you see. So you'll talk about the variables. There might be some variables that you accounted for that the base case did not. You'll talk about what they are and why, some positive and negative externalities. And also you'll talk about the base conditions, what's useful, what's meaningful, but also what you want it to change. And the next couple parts of the clinical evidence table. So this is really just how you can keep organized and kind of evaluate all the literature that you find. So this could be phase 3 trials, phase 2 trials, head-to-head trials, primary, secondary, tertiary literature. Anything you find, you'll put in this clinical evidence table. And anything and everything you use, you should put in these tables so that the judges can see that you went very thoroughly and very deep into your research. So you'll do a study design and evidence grade, which I'll touch back on in a little bit. Drug regimens, the number of patients, the time horizon, the study population, some of the endpoints, efficacy, serious adverse events, and then some of the weaknesses that you found after reading the study. Could be poor external validity, the study population doesn't match up with my health plan, time horizon was too short, XYZ. You guys are very skilled at this, especially the P2s and P3s. You guys have done this a lot. You've been forced to do it for a lot of different classes. Just continue to build upon those skills that you've learned in pharmacy school. You've been prepared for an event like this. Cost effectiveness summary. So if there is an ICER, if there is an incremental cost effectiveness ratio done by an organization, put it here. There might not be one, and that's okay, but if there is one, talk about it. Talk about the study design, talk about the demographics and the horizons, talk about what they thought was their base case. What did they input? What were their data sources? Were they strong data sources? Were they weak? Have they changed since they've done this? People don't really come out with new ICERs every year. This is a once every couple of years, 5 to 10 years, maybe depending on the disease state. So if an ICER came out 5 years ago, more than likely, evidence has changed in the last 5 years, which makes the inputs, some of the inputs might be invalid or need to be updated. And you guys can do that and run your own. And by doing this, you show that you're really doing a deep dive, that you're utilizing your background as a pharmacist, you're kind of critically thinking and evaluating. And then the results, you'll talk about some of the limitations, sensitivity analysis, and base cases. And kind of one of the biggest things here is your comparative clinical effectiveness. So how are you going to grade and evaluate your studies? So a study is really going to show safety and efficacy, but how are you going to use that study in a matrix to compare one drug to the other drug, to the other drug, to the other drug? And ICER really has a really nice chart that I like, and we really utilized last year to grade all of our literature. As you can see on the x-axis, there's a comparative net health benefit. So there's just health. Is this drug substantially beneficial in terms of health? If it's, let's say for an oncology product, if it's like kind of extending progression-free survival by 100%, for example, that's a substantial net benefit. However, if it's maybe still the same or 1 or 2 months, it might be comparable net benefit. So you really have to understand how those endpoints are meaningful. And this is where we get back to finding the clinically important endpoints. So for an oncology trial, overall survival and progression-free survival are important. But for a sleep medication, it might be the quality of sleep, the quantity of sleep, and also how it impacts their day-to-day like work life and school life. And on the y-axis, there's level of certainty. And this is where you kind of have to put on your thinking caps and be great pharmacy students. So you have to look at the study. How was the study run? What statistics were used? What's the time horizon? Are there any kind of conflicts of interest? What's the patient population like? Did they test meaningful things? And this will all come into how certain and how confident you are in utilizing the study. So if it's a low certainty, you kind of think that maybe this has poor external validity and I really don't feel comfortable using this, maybe it's a low certainty. But if it's maybe a really strong phase 3 trial that you're like, wow, this is so robust, they did everything correct, you can put it in a high certainty. And this is another way that you can distinguish yourself from other teams is by really going with a deep dive and really evaluating and discussing how you came to these decisions. Because it's all about this critical thinking and evaluation that really helps separate your team from another team and our chapter from another chapter. It's taking this to the next step and above and beyond with your thinking versus, and not just like the base stuff. It's really critically thinking to understand all the little differences and nuances between studies and how impactful they are in the real world. The background. So this is going to be your favorite part because it's the easiest for a pharmacist. This is just a quick, easy, it's disease background. So you look at the disease burden, pathophysiology, the treatment alternatives on the market, and then background such as like the pharmacology and kinetics. You guys know this. This is like the back of your hand. This is just quick, package insert information, a couple of primary sources, and it's kind of all that. Easiest part. I'm sure all the pharmacists love this part. It's easy. You guys know how to do it. It's kind of just, it's a normal day for you guys. And then last but not least is your methodology and references. In this section, organization is your friend, 100%. So when you and your team start researching, and it's going to be very, very broad. You're going to go from broad all the way down to narrow to find the exact studies that you want to use. When you're going broad, you should really be making note, maybe like an Excel sheet or a Word document, the databases that you searched, what search strategies you used, what kind of keywords you used on PubMed, what Boolean operators you used, really all these little things to make sure that you can find this study again in the future. You'll talk about the study types, like did I include a meta-analysis, an RCT, a case control, a case series, that I just use a patient case, and how significant are these studies? You'll use that matrix from earlier to understand, is it an incomplete, is it really inconclusive, or is it a grade A study? And then last but not least, all your references will be in AMA. And in this section, it really is your way to showcase how thorough you went in your research, what kind of different studies did you evaluate, and especially for new drugs, there might be only a couple of studies, or there might be one RCT plus a case control and a case series, which is okay, but it's your job in this to show how you searched for it, how you evaluated it. Are you going to include it in your decision-making, or are you going to exclude it in your decision-making, and why? And these last 5 steps that I mentioned, it's all about discussion. So you're going to be typing a lot. You're going to be showing and showcasing a lot of your work. But once again, this is where the competition is won. This is where you can really show on paper how your team thought, what discussions you guys were having, what little nuances you were discussing, and how that all factored into your final decision. And then last but not least is the final summary. It's a 1-pager. You'll list the FDA indication, which is just a copy and paste. If you want to put a prior authorization on there, you'll have criteria for PA. So how long is it going to be authorized for? Is it only a 1 year? Is it forever? Is it 6 months? Do you have to get it reauthorized? After 1 year, does the patient have to do XYZ to get reauthorization again? And are there certain patients that you're just excluding from the PA in general, or are there certain exclusion factors? And then finally, the discussion questions. These are like 1 or 2 questions to kind of just make you think a little bit deeper about maybe some of the societal factors or the real life kind of factors of how you would put this into play. And all these different things will come into the discussion questions. They change every year, so it's really hard to predict what's going to happen. But it's usually 1 or 2 questions that your team can talk about and present in like a 2 or 3 page kind of final discussion. And then some just general monograph rules. You want original high quality writing. So a lot of this will be your evaluation, your thoughts, and your discussion. So this is going to be original quality medical writing. You're going to start with the broad scope of evidence. So we as healthcare providers, we thrive off of having the most information as possible. And this really depends on you guys starting really, really broad and then narrowing it down based off your assessment and evaluation as very strong pharmacy students. Next is thorough evaluation of the evidence. You guys, it's going to suck. Sometimes you have to go through the statistical test. And I know that's tough for everyone. It's not the most favorite test that everyone has, but it's these little nitty details that can really help you shine from a different group. Consistent formatting and grammar and spelling, like always. Judges hate more than anything to have different margins and little grammar and spelling mistakes, especially at this high level of a competition and high level of kind of education that we're all at. With that, I will open the floor to any questions that anyone has. I don't see any in the chat right now, but you guys can, yeah, by all means, raise your hand or type them in the chat, whichever one you guys feel most comfortable with.
Okay, Dr. Patel, I have a question here from one of our chatters. How do you determine which studies to include, or do you include them all?
So let's go back. So for example, in your executive summary in your discussion up here, you would only include the studies that you utilized in your decision-making. You would really only say, I came to my decision because of these studies that I thought were well run and well discussed and well operated, that I feel confident in making my decision. In your recommendation, you can also mention that in your clinical evidence evaluation, when you talk about this full narrative summary of evidence, you'll talk about all the positive studies, the strong studies that helped you come to your decision. However, in the clinical evidence table, you are more than welcome to put all the studies that you evaluated, and then in the evidence grade them poorly because you didn't want to use them, and then highlight the weaknesses. Say, this is a study, I graded it a level D, the weaknesses were X, Y, and Z. So you're not including it in your decision-making, but you're showing the judges that you went through it, that you took the time to research it, and then you evaluated it as poorly and made that judgment call of why you don't want to use it, why you don't feel confident in using it. So it's really about placing the correct information in the right portion of the monograph.
Dr. Patel, actually, I have a question as well.
Also, you guys can call me Shivan. You don't have to call me Dr. Patel. You just call me Shivan.
Okay, sure. So what about like studies where there's like strong evidence for like the opposite, or like some sort of toxic effect? Like I'm guessing you might have to add something like that if there's a high evidence grade, right?
Oh, of course. Yeah. So like I said, like I mentioned earlier, there is by no means, you have the option to not include this in your formulary. You have the freedom to do that as a P&T committee. You might say that, yeah, I found some benefit in this drug, but I also found 3 studies that I think are well run and I'm confident in that showed something that could cause death to a high degree, and I don't feel comfortable exposing my health plan patients to this drug. You have the freedom to do that. So sorry, when I say positive, I should kind of reword that. I don't mean positive as in like only good results. I mean positive as in like strong, confident studies, regardless of the outcome, if they're positive or negative outcomes. You want to include, if it's a negative outcome and you say, I'm not going to include this drug, by all means, put that in there. Talk about it in the safety section, talk about it in the efficacy section. And those can be important in helping you maybe make a do not include formulary recommendation versus a definite include.
Thank you.
Okay, if anybody else has questions, feel free. You can put them in the chat and I'll read them off, or you can just unmute yourselves or turn on your video and ask Shivan himself.
Yeah, I had a question. I was wondering how important are presentation skills for the P&T competition? Do all team members need to present?
So I am kind of, so last year we only had one team and we didn't have a local competition. I'm unsure how Scotty, Joseph, and Jacqueline are kind of planning on holding the local competition, but I would anticipate there potentially is some presentation involvement. With that, the more equally that it's split amongst the team members, the better. It really goes to show that you guys worked as a team. And believe it or not, that is part of the rubric to show the teamwork, to show the kind of that competitive spirit as a one collective. So I know it's sometimes it might be scary, it might be daunting to present in front of a lot of people, especially with maybe something you're unfamiliar with, but I would say that this is going to be a great experience to help learn and develop those skills. And even if it is only 30 seconds of presentation, I'm sure it'll kind of help boost that confidence of yours and kind of really help kickstart developing those skills as you kind of progress through pharmacy school.
For sure. Thank you.
Excellent question. Anybody else? You can feel free to put it into the chat. I do, but while someone's typing here, I have a question. This P&T competition, for those of us that were here last year when our school team won, of course, we have you here, Shivan, as well as Fadi. Fadi was the team leader for Team Wayne State. What impact has winning the competition or getting second place, scoring so high in the P&T competition, had for your career or your reputation?
Yeah, it's a great question. So within managed care and within industry, the AMCP P&T competition is kind of regarded as the top or one of the top competitions that you could possibly compete in. They really hold you to AMCP standards. And if you look at the real world, the FDA and many pharmaceutical companies, they will use the AMCP dossier as kind of a base for how they expect information to do. They respect AMCP as the top dog in this kind of information. So this competition is very highly respected. I actually was part of the competition. We got second place after I kind of secured a job, but I do know from conversations with residency directors and things like that, these kind of competition successes can really help you stand out. This is a way for you to kind of highlight that outside of the classroom, you're really doing things to develop your skills and you're excelling at them as well. So really, it's a great way to make yourself stand out. It's a big highlight point on your CV, and also just great experience. In my current role right now, part of my job is to assess what a payer will think of a certain research and development asset that we have. And understanding the types of thoughts and discussions that our payers are having from my P&T experience is really valuable to the team that I have right now. I can provide that information to know that they're going to be looking at this specific data in this way to help them make this decision. So really, it's just a great way to kind of develop those skills. Like I mentioned earlier, any field that you're working in within pharmacy, you will run across a P&T committee eventually. Just building these skills early on will help you succeed and kind of help you stand out when you get to that position in your career.
I actually have another question, but it's more about like fellowships. So you mentioned how like doing well in AMCP competitions definitely help you stand out. For at least what else did you think that you did in PharmD made it seem like you stood out for those fellowships?
It's really, I think, really about kind of getting out of your comfort zone. So for me, I think a fellowship is always going to look for leadership, communication, and kind of someone who is willing to learn. And by doing these extra things, a P&T competition is kind of foreign to you guys. It's not something that you guys always have integrated into your curriculum. So showing that you're confident and you're curious enough to venture out and to do these things. And then also looking back and kind of reflecting on them. Like maybe your team didn't succeed this year. You might look back and say, hey, I wish we had done this differently. I wish we had done this differently. Reflecting, growing, and then maybe next year your team succeeds and wins the local competition. So it's really about learning, growing, and building from your mistakes. I think no one's perfect. It's just if you're willing to learn, those are all really things that will be strong kind of qualities that someone looks for and someone that they want to hire and involve in their team.
Yep. Thank you so much.
Anybody else got a question?
Yeah, I have one for you. Sorry. So with regards to your competition last year, so what was the drug that your team had, and how did you guys approach getting the information that you needed for the P&T competition? Do certain, team members have better strengths that sort of led you with who went after what information, or how'd you guys go about that?
Definitely. So yeah, our drug last year was a drug called brand name Dayvigo, a generic name lemborexant. It's an orexin antagonist. It's used for insomnia. So we had a team of 4 individuals, myself being a P4 and 3 P3s. We 100% broke it up by strength. So one of our team members, she's great at the clinical evidence. She's great at finding the clinical evidence and evaluating it. She did that. A second team member is great at the overall disease burden, pathophysiology, economic burden. He went about and did that. A third was in the process of taking the pharmaceutical economics course, and he has a really big passion for health economics and outcomes research. So he decided to take that part. He built his own budget impact model. He used different softwares to kind of make those calculations. And then me, I had worked at Blue Cross Blue Shield for a summer as a pharmacy intern. So I was able to use that kind of in-depth P&T knowledge to create the discussion questions, create some of the discussion and evaluation of a lot of the information that we had, and kind of put it into a way that is P&T competition and AMCP friendly. So yeah, really play to your strengths. You guys have 4 team members, so everyone will be strong at something. So definitely by all means, play to those strengths.
Thank you very much.
Okay, we still got time for maybe one more question. If anyone, I don't see anyone putting anything into the chat. So I'll remind everyone that if you look in the chat, we have our attendance sheet. So please make sure to sign up for that. And for those of you that have not expressed your interest in joining the local P&T competition, we can still make room for more teams and more members. So Fadi has also put another form in the chat. You can sign up for the competition there as well. And once everyone's squared away and has joined our local chapter with the proper paid dues and membership, make sure to reach out to Niharika. Nikki, as she also goes by, is our treasurer, and she's compiling all that information, and we'll be adding you to our Facebook page to keep you aware of all the things that are going on with the chapter. So Shivan just talked about the drug that was part of last year's P&T competition. Let's turn it over to Fadi. Fadi is our media past president, also part of the team that got second place with Shivan. And he's also our director for our local P&T competition. So he's got more information to show.
Good evening, everyone. Thank you for joining us. I really appreciate you guys. So yesterday there was an update regarding the drug for this year's competition. It's going to be Ponvory, which is a sphingosine 1-phosphate receptor modulator for multiple sclerosis. So that is the drug for this year. What I recommend for you guys is to start looking that up on PubMed, just see what are available phase 2, phase 3 studies. If there is any economic evidence, look into that, just so that you're prepared. So at the moment, there's 18 people that are interested, but it's not fully confirmed because we haven't received not all the payments for the interested students. So please, if you are interested in participating, if you are very interested and you want to be part of a team, you have to be paid up by October 25th. That way we can finalize the teams. If you have any questions, reach out to me. Thank you again to Shivan for a wonderful presentation. We'll be posting more information. We will also be posting this presentation on our Facebook page and on YouTube, so you guys can view it. I will also be posting Shivan's PowerPoint presentation. And then I looked online and I saw that it's not against the rules to share with you guys our monograph from last year. So for our members, I will be posting that on our group page so you guys can view our monograph from last year. Because that was one thing that we struggled with, is we didn't have a monograph to kind of build ours on. So just having an example to kind of structure your monograph on will be very helpful for you guys and lead you guys to success. Once again, thank you guys for attending, and I look forward to speaking to you guys soon.
Thank you, everybody.
Thank you.
And don't forget, our meetings are every Wednesday, the last Wednesday of the month for our general membership meetings. So thank you, everyone. Good night and take care.
Thank you.